Good evening. I'd like to welcome everyone to the COVID-19 vaccine, Facts Not Fear, Vaccine Safety Webinar for Healthcare Providers for February 2nd, 2021. My name is Donald Moore, and I am with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator-asked questions of the expert panelists and 15 minutes of Q&A from attendees using the chat functionality. Attendees who join by telephone who have questions should send their questions to epnrtraining@vdh.virginia.gov. Your feedback is requested regarding the panel discussion webinars. Please complete the survey that's provided in the chat. For accessibility information regarding this webinar, please refer to the URLs provided in the chat. Your experts panel for this evening is as follows. Dr. Norm Oliver, Commissioner, Virginia Department of Health. Dr. Tyson Bell, Assistant Professor of Medicine, UVA Health, Division of Infectious Diseases and International Health, Director of Medical Intensive Care Unit. Dr. Gonzalo Behrman, Associate Professor of Medicine and Infectious Diseases, Associate Hospital Epidemiologist at VCU Health System. Your moderator is Dr. Muriel Azia Evans, Director of Mental Health and Wellness, Health Brigade. I'll now turn it over to Muriel.
Muriel, you're muted.
That's a good place to start. Thank you. As we kick off this informational panel, I think it's good for us to review where we are with numbers. So my first question is, Dr. Oliver, tell us a little bit about the COVID numbers in Virginia, if you will.
Certainly. Can you hear me okay? Okay, great. Well, COVID is definitely still with us. If any of you were following the numbers over the last several weeks, we were having an unprecedented surge in the cases. If you remember back last April when we were seeing 1,000 cases a day, and that was quite frightening, we were 4 or 5 times that amount in January and in some weeks in December. This holiday spike began to taper off very recently. Cases have now dropped down into around the 2,000 range, which is still much higher than it was last April. And that's indicated just in our general figure for the incidence of COVID-19 in the Commonwealth, which is about 49 cases per 100,000 people in the state. So it's still running rampant out there, and we need to continue to do all the measures we know work in helping to stop the spread of COVID-19, wearing masks, watching our distance, washing our hands. So keep all of that up. Deaths now number over 6,500. Of course, there's light at the end of the tunnel now with the advent of the vaccines to protect us against COVID-19, which will be the focus of our discussion tonight. With respect to vaccines, we have since mid-December been on a campaign to vaccinate as many people as we can, given the scarce supply of vaccines that we have. We've now vaccinated some 873,000 people, at least in doses that have been administered. About 742,000 have received their first dose. People who are fully vaccinated so far, almost 131,000. So we have a really long ways to go to get to the point where there's nowhere for COVID-19 to live. One other point I wanted to make with respect to the spread of COVID-19 right now across the Commonwealth, I think it's really imperative that we get as many people vaccinated as possible and continue those other mask wearing and other methods for stopping the spread, given the advent of these new variants of the disease. The Virginia Department of Health is currently doing a lot of surveillance, and we'll be reaching out to our academic partners to help us in doing this. We know that the variant from the United Kingdom is already here in the Commonwealth, and the South African variant has been identified in Maryland. If either of these variants take off, they're both more infectious than the other main variant of COVID-19. It could lead to yet another surge. So the importance of those things cannot be stressed too much. Thank you, Mrna.
Thank you. Dr. Oliver, this question is also for you. You started to speak a little bit about this. Can you discuss the allocation phases of vaccine distribution that's being followed? Vaccinate Virginians?
The Department of Health adopted the CDC's recommendations on this and their advisory committee on immunization practices. And in the first phase of vaccination, the idea was to deal with both a population of essential workers, people whose work is absolutely critical to our being able to function as a society, people who keep the lights on, keep us fed, transport us from place to place, and also deal with a population of people who are at particularly high risk of having serious disease if they got infected with SARS-CoV-2. So and that phase one was broken up into 3 subphases. Phase 1A, the essential workers that we were dealing with was healthcare professionals, and the vulnerable population were residents and staff at long-term care facilities, skilled nursing facilities, long-term and skilled nursing facilities and assisted living facilities, group homes, residential facilities, that sort of thing. Group 1B was initially announced as being frontline essential workers. So this would be people who were having lots of interaction with the public, who could not telework and were essential workers. And the vulnerable population was age 75 and older. You may recall that several weeks ago, the federal government announced that they really wanted people to add into that 1B category people 65 and older, and any adult who had chronic medical conditions that placed them at increased risk for serious disease, and also promised that they would release a new batch of vaccines and stored up second doses. Virginia and other states went ahead and added that additional population to 1B, and we found out a few days later that in fact the extra doses were not available. So we're now in a situation where we have all those people eligible for a vaccine, but we're still receiving a very small quantity of about 100 to 110,000 doses a week.
Thank you. People are concerned this vaccine was approved so quickly while other vaccinations have taken years for approval. Dr. Bell, can you talk about the emergency use authorization process and how it differs from standard approval process and how we can be sure the approved vaccines are safe?
Sure. So really good question. Well, I heard a little feedback. This looks like that's gone though. So I'll first talk about what EUA is versus full FDA approval, and then go back to address the initial question, what about this vaccine and the developmental timeline? Emergency use authorization is basically an acknowledgement and a mechanism that the government uses, saying that the full approval process has a lot of red tape and it may not be appropriate in a time of an emergency. So a global pandemic of historic proportions, once in a lifetime sort of thing, definitely qualifies. And EUAs have been issued, for instance, before with the Zika, MERS, and H1N1. So it's a common mechanism used during situations like this when we have a rapidly spreading virus or pathogen that's causing a lot of people to get sick. There are basically four requirements for an agent to qualify under EUA, and I have them written down here. One, there needs to be a declaration that there's a public health emergency with a significant potential to affect either national security on the health and security of United States citizens living here or abroad. So, checkbox number one for that, for sure. Number two, based on the totality of evidence available, it's reasonable to believe that the product being considered may be ineffective in either preventing, diagnosing, or treating the life-threatening illness or condition. These therapeutics that we were looking at, remdesivir, et cetera, the monoclonal antibodies on the treatment side, and now the vaccines. Three, the known potential benefits outweigh the known and potential risks of the product. So in other words, we think that is safe and we think it'll have a benefit, and that ratio or that benefit's going to far outweigh the potential risk. And then four, there's no other fully approved available alternative treatment for what the product is addressing. So if there was a fully approved vaccine for the coronavirus before all this started, then that would be great. But of course, this was a novel virus, so there wasn't anything in a vaccine platform to address it. So those are the four requirements. Now, the one difference when it comes to these vaccines versus the normal EUA process is that when we saw with some of the earlier agents that were approved, there can be a lot of flexibility in the data that you usually will have before you go through our emergency use authorization. So in theory, it would have been possible to, for instance, approve these vaccines after a phase 2 trial showing that there was efficacy before the phase 3 was completely published. And there was actually a push from the previous administration to try to get some of these vaccines approved on their earlier timeline. But if you may recall, the FDA actually pushed back and said, no, we're going to have an enhanced level of requirement for the data, have the full phase 3 trial completed, and we can analyze it and then make a good decision. So they actually took the usual lower hurdle for EUA and made it higher so that it came very close to what you would normally require for a vaccine in the first place. Now, the one difference between what you would normally see with a vaccine trial and the EUA vaccines that were approved recently, the Pfizer and Moderna, is that follow-up period was a little bit shorter than you would see with the normal vaccine trial. Normal vaccine trial, the follow-up period would be about a year or so. And for Pfizer and Moderna, the median follow-up time were 2 months after the phase 3. Now, that goes back to the original question. This vaccine was developed in a year's time. How do I know that it's safe? It looks like it's effective, but what do we know about side effects and long-term effects and things like that? So I'll first go back and start with the 3 basic steps that you need to bring any therapeutic from development to the market. The first is that you actually have to develop the thing that you're trying to study and get approved. So these vaccines, the important thing to get across is that it wasn't like someone completely made up the concept of an mRNA platform or messenger RNA. The technology had actually existed for over a decade and had been studied in various sort of platforms like rabies, et cetera. So it wasn't a novel technology. They did need kind of funding and kind of new development and innovation to get across that last hurdle. The molecules are not very stable in your body, and you need to construct things around them to protect it so that it can actually get the message to your cells to make the spike protein that gives you the immune response. So it's kind of like we had the technology at the 20-yard line in the red zone, and then we got it across the finish line with the boost of funding from Operation Warp Speed. So didn't start from scratch. The second is that you actually have to study it in a scientifically rigorous way and have clinical trials set up that can get to endpoints that you can actually tell if the therapeutic agent works or not. Now, fortunately / unfortunately, the trials were happening in the midst of a global pandemic where cases were going up as the days went on. And so the trials were able to meet their endpoints relatively quickly because we were able to see that difference because a lot of people were end up getting infected because that's what was happening in the world. In addition, there was a lot of cooperation between the trial sites to make sure that we were looking at the same sort of outcomes and inclusion criteria so that you could easily compare them. And we were able to combine in some instances like a phase 1 and a phase 2 or a phase 2 and a phase 3. So the ability to compress that timeline while not shortcutting the science, but getting down on the red tape and the approval process and all that was very streamlined in the trial process. And then 3 is, you've developed it, you've studied it, and now you have approval. You actually have to distribute it and get it out there. And, while there have been some issues with vaccine distribution, we did have several doses that were already ready to go once the trials were approved. So the healthcare workers initially got their doses. I think it was approved on a Friday, and the first doses went out on Monday. And that's very unusual, right? Because usually we'll wait until the approval before you start to manufacture and distribute. But because Operation Warp Speed, the federal government actually contracted with Pfizer, Moderna, and others to actually make doses of the vaccine before that approval was made, so that once that approval went through, assuming that it did go through, you actually had doses that were ready to go out the door literally that same weekend. So in totality, we're able to compress that timeline using existing technology, accelerating it, accelerating the clinical trials timeline, and then having manufactured doses while the clinical trials were going on so that you were ready to get them out the door. The 3 independent bodies that will normally review and make sure that data is safe and that it's effective remain intact. So the Data Safety Management Board, the DSMB, was active during the clinical trials. They're an independent body. I always stumble over this, but the Vaccine and Biological Related Products Advisory Committee, or VRBPAC, which is the independent advisory body for the FDA, independent experts, they ensure that and make the recommendation for approval or authorization. They remain intact. And then the Advisory Committee on Immunization Practices, housed in the CDC, again, independent experts advising the CDC, that body remained intact. So all of that remained intact, so we can be assured that there's been a scientifically rigorous process, that people that did not have skin in the game when it came to being pressured by the federal government or the headlines, they were really looking at the science. And because of this vigorous effort, we actually have way more data points than we would normally have for a clinical trial. Most clinical trials will have between 4,000 to 6,000 people. We would call that a success. For Pfizer and Moderna, we have 75,000. So orders of magnitude higher than what we would normally see for a vaccine trial. So the numbers really stand up for themselves. So we can be assured that this is a safe and efficacious product.
Thank you. Great. Dr. Bierman, can you help us understand the 2 approved vaccines? How do the mRNA vaccines work? What additives are in them?
So good evening. I think as my colleague, Dr. Bell, so eloquently stated, the mRNA vaccines isn't something that just came out of scratch. It was just developed over the course of the last 6 months or even 1 year. It's been in development for greater than 10 years. These vaccines are a new delivery mechanism in which the mRNA is delivered to the tissues, really in a lipid capsule, and really tricks the body into thinking that we have a COVID infection and producing antibodies. So it's very potent in that respect. With respect to the Pfizer and the Moderna vaccines, it's really not that much of a difference between them. It's kind of like a Coke and Pepsi difference. I know some people are purists and like Pepsi and Coke. I get that. But what I'm alluding to is really the same delivery mechanisms, slightly different time between dose 1 and dose 2, roughly the same efficacy and outcomes, 94, 95% efficacious in preventing clinical infection with or symptomatic infection with SARS-CoV-2 and severe infection with SARS-CoV-2. And in terms of additives, the first thing I would like to say is there is no thimerosal, which has always been a concern for people. Thimerosal or mercury is one of the chief additives in a vaccine, and we don't have egg products or egg proteins that could trigger certain allergies. Really, the biggest additive is going to be sucrose and also the lipids, the polysaccharides and lipids that are used to really encase the mRNA for the delivery.
Great, thank you.
Yes.
Dr. Bell, can you tell us what types of side effects are likely to occur from the vaccine, and can they be managed with anti-inflammatories or antipyretics?
Sure. Great question, as always. I'll share my experience and share some of the data as well. So I received the vaccine early part of January. Just had some injection site pain with the first dose, which is extremely common. Upwards to 80% or so, or even higher than that, we have injection site pain. That was it after the first dose. After the second dose, same injection site pain, but I did have some chills that evening that no fevers or anything like that. And then when I woke up in the morning, I felt a little generally achy, but by noon that next day, it felt completely normal. That's kind of in line with what a lot of people have experienced. As far as the clinical trials data, you can pretty much count on having some injection site pain. That's extremely common. Things like nausea or things like headache, chills, aches, and pains, a little less frequent, fever even less frequent, but there were plenty of people who had some of these side effects. Anecdotally, my colleagues, most of them had a similar experience with the first dose. I did have one colleague who had a fever and chills after that first dose, and then had them after the second dose as well. But I would say if you had to pick and didn't have the opportunity to take both days off after dose 1 or dose 2, I would prioritize dose 2 because that seems to be a little bit more of a boost to the immune system. So that would be a recommendation there. But very tolerable otherwise, no reactions that land you in the hospital or to the emergency room or anything like that. Generally self-limited, last between 24 to 48 hours or so. Now, antipyretics, so things like Tylenol and Motrin, things like that, are they okay to take? Generally, that's fine to take. The recommendation from the CDC is to not take it prophylactically or on a routine basis, but to use it if you actually have those symptoms. That's not because someone thinks that if you take a Tylenol, it'll completely botch the vaccine. I don't think that's the case, but we just don't know enough data about how those immune reactions could be affected by it. For my colleague who did have the fevers and chills after that first dose, she actually took a Motrin ahead of time before the second dose, and I think that was reasonable, thinking that she would have a more severe reaction. So as long as you aren't using it routinely, if you have symptoms, you can certainly manage that with the anti-inflammatories.
And what are your thoughts on severe allergic reactions that we do hear about sometimes?
Yeah, so this was one of the initial stories that came out when there was that larger rollout of the Pfizer vaccine. And interesting, this wasn't actually seen during the course of the regular clinical trials, but we always learn more about vaccines or therapeutics once they're rolled out to the general population. Now, anaphylaxis is a severe life-threatening reaction that involves symptoms like throat closing, your lips swelling, tongue swelling, things like that. Usually happens immediately after receiving the agent and is treated with EpiPen or injectable epinephrine. We learned that we did see a signal that there was a slightly increased incidence of this anaphylactic reaction to both the Pfizer and Moderna vaccines, and it's kind of settled out after a report came out. Around 1 in 100,000 for the Pfizer vaccine and 1 in 400,000 for the Moderna vaccine. In all instances, the people who had these reactions were able to be treated, recovered well. A couple of people went to the hospital overnight, but were discharged, and everyone who was still happy that they had received the vaccine. So this is something to be aware of, but luckily it's still very, very rare. I think, as time has gone on, that indication to potentially avoid getting vaccination if you've had anaphylaxis reaction to one of the ingredients of the vaccine has kind of expanded to include what's called severe reaction, which may not quite meet the level of anaphylaxis, but is a reaction that happens within the first 4 hours of receiving that vaccine. So for instance, if someone did have a reaction that qualified under that criteria to the first dose of vaccine, the recommendation is not to get that second dose of vaccine. I think what becomes confusing is that there are plenty of people who have a history of allergies, sometimes not severe, sometimes anaphylaxis, and people that are carrying around EpiPens. And it can be confusing how to advise those people. I would say, first and foremost, have them speak with their physician and person in their healthcare team who kind of manages that condition to kind of figure out exactly what they're allergic to and the history and whether it qualifies and how to route them appropriately. But in general, as long as you don't have an anaphylactic reaction to those injectable ingredients, to vaccines, and if you do have a history of anaphylaxis otherwise, the recommendation is to go ahead and proceed, but then to have a longer monitoring period after you receive that vaccine. So instead of 15 minutes that's recommended for at least everyone, you extend that to 30 minutes if they have a history of anaphylactic reactions. But I think this is a situation that may change over time still, so keep track of it, but make sure that your patients are speaking with their regular medical providers.
Great, thank you. Dr. Oliver, this next question is for you, and it's somewhat related. What's in place for immediate and long-term post-vaccine adverse event monitoring in general?
Well, as Dr. Bell just mentioned, the evidence would indicate that people have um, anaphylactic reactions usually occurs early after receiving the vaccine. So we routinely observe everyone who gets the vaccine for 15 minutes in just an overabundance of caution. As Dr. Bell laid out, it's a very rare reaction. But we want to be safe. So people are observed for that 15 minutes. And if they have a history of anaphylaxis or anaphylactic reactions in the past, we'll observe them for 30 minutes. We encourage people to utilize things like there's an app you can get from the CDC for your smartphone called V, as in vaccine, safe. It monitors, helps you monitor your symptoms immediately following getting the
Where
vaccine
my mother lives, and she has not been able to get the vaccine either. But there was a gentleman who drove down
for several days, and actually will then periodically ping you for a couple of weeks after that. And of course, it's always advisable to pay attention to your symptoms and report any symptoms that you think might be related to your having received the vaccine to your care provider.
Thank you. Wonderful. Dr. Behrman, can you speak to what we know about vaccinating special populations? So pregnant women, children, immunocompromised, I can't say it, patients?
Sure, sure. So pregnant women are indeed at risk for more severe COVID-19 disease. Although pregnant women were not studied in the vaccine protocols, they are under the list of people who are recommended to consider getting the COVID-19 vaccine. What's important to know is that the vaccine is not a live virus vaccine, so in theory, it should not pose any threat to the fetus not being a live virus vaccine. What it comes down to is it's a matter of individual choice for pregnant women to have that discussion with their obstetrician gynecologist as to whether to proceed with the vaccine. Now, one thing that was recently published, I believe it was published yesterday or today in JAMA Pediatrics, was a study on placental or vertical antibodies from the mother to the infant. So mothers who were confirmed infected with COVID-19 definitely passed on IgG antibodies onto their infants, which would certainly be encouraging with respect to a vaccine. A vaccinated woman not only would be protecting herself by receiving the vaccine, but potentially protecting the infant with vertical antibody transfer. So that would be certainly a positive. Now, with respect to other populations, I believe you mentioned children. Again, that wasn't studied, children under 16, so there's no formal recommendation to vaccinate children, at least en masse at this moment. And last but not least, immunocompromised patients. Again, it's a potential body of patients that are increased risk for COVID-19 disease or infection. There's certainly no reason not to, immediate contraindication to not vaccinate, for example, HIV/AIDS patients or patients with immunocompromised conditions. The caveat is that the response or the immune response may not be as robust in those individuals because they don't have an immune system to mount that antibody response. Therefore, if we're expecting 95% efficacy of the vaccine, it may not necessarily play out that way in immune compromised individuals. Nevertheless, given that it's not a live virus vaccine, it's likely safe.
Thank you. Dr. Bell, if someone has already had COVID-19 infection, should they still get vaccinated? And if so, how long do they need to wait before getting vaccinated?
A good question, and unfortunately a common one because so many people have become infected with COVID-19. But the recommendation is that yes, go ahead and get the vaccine, and particularly because we know that reinfection with the SARS-CoV-2 virus and getting COVID-19 is possible. It does tend to be rare within the first 90 days of infection, and that's thought to be the best immune response during that period. We have seen it, within that window, but most of the time it's going to be outside that window. But as far as is it more severe, can it be less severe? I've seen and we've seen either case. So it's something to still consider after you've had COVID-19 infection. The recommendation is to wait until you've recovered from your illness and to clear isolation. And that goes, that's a specific case for COVID-19, but in general, if you're sick with anything, you should not receive a vaccine. You want to wait until your immune system is recovered, fighting whatever it is you're infected with, back in tip-top shape and ready and primed to make that immune response to the vaccine that you're receiving. Same case with COVID-19. That one caveat is that if you had COVID-19 and you were treated with the monoclonal antibodies or convalescent plasma, so in other words, you had antibodies infused into you, they could potentially interfere with the vaccine itself. And so the recommendation from the CDC is to wait 90-day period before you receive that vaccination to make sure that that's kind of washed out.
Thank you. Dr. Oliver, what is the mechanism in place for documenting vaccine administration and for second dose reminders?
CDC put out a system called VAMS, Vaccine Administration Management System, which tracks the scheduling and provision of doses of the vaccine to people. We have an immunization registry, the Virginia Immunization Information System, or VIS, which records vaccines when they are given, and we know who has received their first doses and can reach out to people about their second doses. There's also a system called VTRAX, which is more about the inventory of doses in any given location. The Virginia Department of Health is currently installing in waves across all of our 35 health districts something called PrEP Mod. This is another scheduling system which we think is more robust than the others. This scheduling system will allow people to get online, register, and get scheduled for appointments, and also will allow us then to reach back out and touch people about coming in for their second appointments. In fact, PrEP-Mod will allow us at the time of your receiving your first dose to schedule you for your second dose, which will greatly improve the ability of keeping on top of that, because we definitely want people to receive that second dose. For those who don't have computer access or don't feel very facile at using that, one of the things that we're doing now is we're also in the process of revamping our call center, which got pretty, frankly, overwhelmed this last month or so, and we're greatly expanding it and including in there the capabilities for scheduling, and that will aid in this process as well.
Great, thank you. All right, this is my favorite question. Dr. Oliver, how can mental health professionals find out if they're vaccine eligible? And if so, where and where do we go? And does it matter where and who we work with, whether you're a mental health professional that works inpatient or outpatient or with adults or with children, does that make a difference?
I think if you go to our website and you look at, if you go to vdh.virginia.gov, you'll find a button there for COVID-19 vaccine campaign, and you can get to a page that lists all these phase 1A, phase 1B, phase 1C. The folks who are in health professionals who are in contact daily with patients or clients, depending on your specialty, right, are considered at at higher risk and should be covered in phase 1A and 1B both. Some situations, for example, if you work in group home or some of the smaller residential facilities, I think those are particularly qualified under 1A.
And I think you've touched on this already. The general public, to find out when they were going to be eligible, same website, I imagine. And if somebody doesn't have a computer or access to sign up online, your suggestion is to use the phone. Is that correct?
Use the phone. Yes. So vdh.virginia.gov, click the button that says COVID-19. The phone number is 877-ASK-VDH3, the number 3. And you can get information that way. You can also go to our website. If you don't know the name or number of your local health department, you can go to that website and there's a finder app there that will point you to your nearest local health department, and you can contact them as well.
Great, wonderful. Thank you. Can you speak, Dr. Oliver, to whether or not there's a cost or a copay for vaccines once people get them? And are there any residency requirements?
There's no cost, there's no out-of-pocket cost for the recipient of the vaccine. The administrative costs for delivering the vaccine, giving this dose, can be billed to commercial insurance or billed to Medicare or Medicaid. And for those who are uninsured, HHS has a provider relief fund that will pay the provider for those administrative costs. So in no situation should anyone have to pay anything. The CDC has not recommended, and we don't follow any strict residency requirements. This vaccine is a national resource. It's allocated out of Washington as on a proportional basis based on population. And we do the same thing within the Commonwealth. We allocate the doses that we have each week by population across the various localities. For that reason, we encourage people to get vaccinated in the place where you live, unless you or where you work. In the case, like with healthcare professionals, they got vaccinated in healthcare systems where they worked, or in the office where they worked. Teachers, we're trying to do points of dispensing in the schools where they work. That sort of thing. But it's not a strict requirement.
Right. I imagine if somebody's been displaced because of COVID and they've been here 6-8 months, they don't have to go back to their original location.
We're not going to turn people away if they qualify in other regards in terms of their risk, their age, or occupation.
Great, thank you. Dr. Behrman, what do we know about whether the vaccine will work against the new variants that we keep hearing about being reported?
Well, all the reports so far would suggest that the current vaccines are still effective against the UK variant, and that's encouraging. What's discouraging or concerning, and I think Dr. Oliver alluded to this earlier, is the arrival of the South African variant in the United States. There was a paper that was recently published, I think it was last week, and it may have been a preprint in BioRx, looking at sera, post-vaccine sera, and whether or not it can neutralize, it's an in vitro study, the South African variant. And what was observed in that small study is that it was less effective. It wasn't 94, 95% effective. The efficacy went down to the 50s or low 60s%. Again, in a small group, in a preprint, hasn't been tested in vivo, unmasked yet. But that would suggest that the vaccine would be less effective against the South African variant, which is reason to be concerned, particularly if such a variant takes hold extensively in the United States. Then our vaccine hopes and desires may be not as robust.
Thank you. Can you also answer, will being vaccinated affect COVID testing results?
So being vaccinated in theory should not, if someone is vaccinated or post-vaccine and truly infected with COVID-19, in theory, being vaccinated should not have an impact on PCR detection. So the PCR detection should still work. One would imagine that an individual is post-vaccine and infected may have less severe disease and therefore have less viremia. And by having less viremia, less viral shedding, you could have a less positive result on a PCR, so to speak. But I don't anticipate that we're going to have mass false positives because someone is post, or false negatives, actually, because someone is post-vaccine.
Great, thank you.
Sure.
Dr. Bell, can the vaccine have interactions with medications a person may be taking?
Yes, good question. I'll point out that in these trials, the Pfizer Moderna trials, 1 out of every 5 participants had a chronic condition, conditions like diabetes, high blood pressure, history of strokes, chronic lung disease. The most common conditions were diabetes and COPD. Plenty of these patients were taking the common sorts of medications for blood pressure and diabetes management, heart medications, et cetera. So there's no expectation that the medicines will interact or interfere with the vaccine efficacy, or that the vaccine itself will decrease the effectiveness of those common medications.
Great, thank you. Dr. Oliver, can you share with us VDH's plans for vaccinating underserved communities and vulnerable populations, please? Oh, I think you're muted. Oh.
You would think after months of doing this, I'd get the hang of that, right? In the Commonwealth of Virginia, as across the country, particular populations, particularly communities of color, have been the hardest hit by COVID-19. Recognizing that fact, we're doing what we can to try to ensure that we have equitable distribution of the vaccine. There's some challenges to that. Initially, as you know, we focused on healthcare professionals where the African American, Latinx, and other populations are less well represented, and that's revealed in our numbers when you look at how many African Americans and other minority population people have been vaccinated so far. So going forward, one of the things that we're doing is we're mapping out right now community vaccination sites that have large throughput. Quite often when you have large sites like that with lots of throughput, it's in communities and in areas that are hard to get to by vulnerable communities. So we're planning, DMV is going to give us vehicles, and we're planning on doing things like transporting people to these sites. In rural areas, say in far southwest Virginia, for example, it doesn't make a lot of sense to do a mass vaccination site outside of, say, maybe Bristol or someplace like that. Meanwhile, to get back into the mountains and reach the population, we're going to have to send mobile sites there as well. We're also having lots of discussions with faith leaders and other trusted leaders in these communities to do things like have, just this past weekend down in Chesapeake, I believe, there were a couple churches in the African American community that organized that vaccination event that vaccinated over 1,000 people. So by doing these sort of targeted things in those communities, we hope to reach out and ensure that this most vulnerable of our population receives this vaccine.
Great, thank you. Dr. Bell, can you speak on how mental health professionals can best help with vaccine hesitancy and anxiety?
This is a fantastic question, and it's actually so good. I knew it was coming. I posted on Twitter to some mental health professionals that I know to get some groupthink around it. And I got some really good themes coming out of it. So I think the first theme that emerged was that we really need to try to normalize the feeling that people have. Vaccine hesitancy is not my favorite term because it implies that people should be rushing to break down the doors to get the vaccine when in actuality, most of us are actually late adopters. When I asked my wife to marry me, she was appropriately hesitant because she knew me. But when it comes to the vaccine, many of us have questions. And those questions are normal because this is something that's going to be injected into your body. So I think the first step is just to normalize that feeling and say it is okay to have these questions. What are they? and really dig down deep, but make it a safe space for the person that you're talking to be able to openly share what exactly their fear is. So that was the first one. The second one is to approach from a motivational interviewing perspective. And you all on the call know this a lot better than I do. But this is, I'm getting some laughs, but this is the way to let someone have internal motivation to make a decision that they may be ambivalent about and to find the internal courage to get there. By and large, this is a intensely personal decision, and people need to be armed with the information that they need to make a good decision about their health and their bodies and their families. Now that gets to, where do you actually send people to get this information so that they can make a good decision? Because, what's also pointed out on the thread is that a lot of times mental health professionals will have the most regular contact with someone as opposed to their regular medical doctors. Mm-hmm. So where do you actually refer someone to get information? So I found the public health websites, the CDC website and the Virginia Department of Health website, they have an FAQ section, have been really good. I will say that I think the VDH website is actually better. And I'm not just saying that because Dr. Oliver is on the call, but they do a really good job of going through a lot of more questions than the CDC. But at the same time, they're more succinct and they make good recommendations to kind of tie everything together. And it's much more extensive, and it has a search box where you can kind of put in, diabetes and find out anything that's related to diabetes and medications and kind of find out that way. So I would refer people to that website to get that information that they need. And then, another point was to share vulnerability if you're comfortable doing that. If you've had any concerns or hesitancy around the vaccine and want to learn more and had that experience of trying to learn more and think through the trials and think about allergic reactions and things like that, sharing that is a really good way to make that a safe space, to make it so that your patient or person that you're talking to doesn't feel like they're abnormal for having those feelings, and that the person that they trust also had that same journey. It really makes that experience so much easier for them to approach. So those were the main sort of pointers that came out of that discussion. If you want to kind of read through it, you can look at my profile on Twitter. I posted it yesterday, and I've got just a bunch of mental health professionals who are just going through and talking about their pointers for dealing with this.
Great recommendations. Our last question goes to Dr. Behrman. Let's talk about other vaccines on the horizon. What vaccines are in the pipeline for approval?
Yes, great question. But first, I really like the comment about the motivational interview. I think there was an article or an op-ed piece yesterday in the New York Times by Adam Grant about that. So I'd encourage people to look into that. I think I don't know the title, but I'll put it on Twitter very shortly. So back to your question, what vaccines are in the pipeline? I think the one we should be most interested in right now is the Johnson & Johnson vaccine, which is coming soon. So what's different about this vaccine? Well, there's a bit of nuance here. It's not an mRNA vaccine. It's actually a DNA vaccine. Also, the delivery mechanism is a little bit different. It uses an adenovirus, non-live adenovirus vector for delivery. And then you have the development of antibodies post-delivery. But here's the catch. It is more stable, which is great, requires one dose, which is even better. You don't have to have the extensive freezing. You can put it in a refrigerator for, I think, 30-something days. So it makes it much easier for logistics. But the twist is it's not quite as effective. What's been reported is that the efficacy is roughly around 60 to 65, 67%. So maybe it doesn't hit that 94, 95% efficacy threshold, but certainly is much easier to deliver en masse for public health purposes. So that's really the vaccine to be watching at this moment.
Dr. Behrman, I actually had a question for you, if I may.
Yes.
So one of the things that I've been thinking about is that, are we actually able to compare apples to apples, because the Moderna and Pfizer trials were done with actually a different version, an earlier version of the coronavirus. So the Johnson & Johnson trial actually had these variants that were circulating, and they were in the countries where they were circulating. So who's to say if the Pfizer Moderna trial were repeated in this day and age with those variants, would we have those same numbers and that big difference? And I don't know the answer to that. Wondering what your thoughts are.
That's a great thought. And if I guess we were to do a thought experiment, you're probably spot on. that the variants have changed and you may not have as great of efficacy with the Pfizer and Moderna vaccines were those trials to be replicated today. So great thought. I think what we'll have to do is certainly see how it plays out in the real world as you have greater degrees of vaccination across the populations and what impact that will have on transmission, not only this year, but moving forward to the course of the next 6 months, 1 year, et cetera, et cetera. Great question.
I would like to, hi all, this is Wendy Klein. I would like to take advantage of the expertise on the panel and follow that up. Novavax is also in the pipeline, and the UK trial showed great efficacy. I read 89.3% at the end of the phase 3 trial in the UK. What are your thoughts about that one? I throw that to Dr. Behrman, Dr. Bell, Dr. Oliver.
I'll defer to Dr. Oliver first, and then I can certainly get involved.
No, that's okay. I'm interested in what the two of you have to say on that one.
Well, again, it's an exciting vaccine. It's going to give us an additional option in terms of our vaccine armamentarium. And as we're seeing that the logistics of delivering the current vaccines, the Pfizer and the Moderna, are complicated, they're definitely a complicated process. The more options we have on the menu, I think that'll be a boon for public health and for vaccine access.
I have one.
Yeah, the advantage of the Novavax platform is that it's a well-established platform for vaccine delivery. It's based on a protein subunit. So it takes a little bit longer to messenger RNA, and that's why the trials for messenger RNA were able to go along much quicker. But you actually make a spike protein simulated in the lab and then attach it to a vector that can then deliver it. And one of our pneumonia vaccines works very similar to that. So there's a comfort level with the technology that might serve as an advantage, and it might be an option for, say, if someone has an allergic reaction to one of the Pfizer or Moderna vaccines, they can have a different additional platform to consider taking.
So following up on that, we live in our own national bubble. We hear about other vaccines that are being developed around the globe in Russia and India, China. Are those very different from the mRNA vaccines that are approved here?
So the Russia vaccine that was approved, it was actually approved a while ago in phase 2, and that was a bit controversial. But this is another adenovirus platform, so very similar to the Johnson & Johnson. I think it's a different form of the virus that doesn't cause symptomatic infection, but can cause infection and deliver the spike protein DNA that then makes the spike protein that you make an immune response to. And I believe their efficacy was around 91%, if I'm not mistaken. So again, looks like that's a good product. I haven't seen the data actually looking into that, but it looks encouraging. I think what this is going to complicate, we have a global society now, and travel requirements is going to become very complicated in the midst of this. And so I think that what this might mean is that there are certain vaccines in certain countries that might qualify you to be able to enter another country based on the efficacy of that vaccine and the trustworthiness behind the data or so. But I think it's good to have these different candidates that look like they work using similar platforms.
Yeah, and if I may add to that, with the Sputnik vaccine, obviously we don't have that in the United States, but other countries are using it, not just the Russians. For example, my home country of Argentina, that's really the primary vaccine that's being used, that the Argentine government has been able to purchase. They're far behind on the Pfizer purchase. So, it's certainly a viable option. And I think the efficacy that's been reported, although I didn't see this in a peer-reviewed publication, is roughly 90%. Does that sound right, Dr. Bell? About 90%. So, that's not too bad. That's not too bad at all. Now, if we go back to Novavax really quickly, that 89 or 80+% efficacy was in the United Kingdom, which almost certainly must have had UK variants, the ones we're concerned about. So that's very encouraging that if the Novavax vaccine is really that effective, particularly against UK variants, that may have a significant role, particularly as that variant populates globally.
Yeah, it's hopeful. There's a light at the end of the tunnel, but we're still in the tunnel.
Oh, yeah.
Our audience tonight is small. If anybody has questions, please put them in the chat. In the meantime, I'll take a moderator's prerogative, and I'm going to throw back the hesitancy question because Muriel, Dr. Azria Evans, is an expert as well. Do you have any pointers as a mental health professional to help people deal with resistance, anxiety, myth busting? How do you reassure people that its vaccine is worth the risk?
Well, you might have seen my face light up when you mentioned motivational interviewing. So yes, I'm a fan. I think normalizing the fear, the anxiety. I think anytime somebody is feeling pushed or pressured, it tends to make us respond in a defensive way. So most people know the number one therapeutic response is to listen and to validate fear, whether it's based on 100% fact or not, to validate the emotion and the feeling, and then maybe explore where that information is coming from, connect your clients with reputable sources like VDH, things like that, and really kind of follow the client along their journey of hesitancy. You know, most people, you know, it's not always going to be just fear of a needle. Sometimes it's really rooted in, especially for certain populations, it's really an historical trauma around the medical profession, around what to believe and what not to believe. And, you know, people may be quite knowledgeable about what's written on VDH, but then they also may be hearing other things from family and friends. So I think it's just validating that this is not an easy decision, that we're dealing with a lot of information that's new to us. And anything around, I think, medicine, especially when, you know, I have to admit, half of what I had to look up a lot of these words before coming on as, you know, not an MD. So recognizing that, you know, it can be hard as a layperson to truly understand what people are telling you, you know, that what's being explained by the medical community. So I think for me, with my clients, I can speak to them is I'm okay disclosing. So I've had it and I'm okay disclosing my experience. I normalize the fear. I normalize what they've heard. I direct them to resources that I feel are kind of appropriate and accurate. And then I'm there to listen and answer any question I can answer. So the key is really feeling like concerns and being wary is appropriate, and really just them being cautious, which is a positive strength, right? We don't typically want people to jump into something that they're not well versed on or don't have a good information on. That's something that we generally don't recommend. So I would use a strength-based approach of saying, good for you for checking at everything and getting your questions answered and making sure this is right for you at this time, and then kind of moving from there.
I welcome any other thoughts. Dr. Oliver, you know, one of the things that I keep hearing about is resistance of healthcare workers who, for example, nursing home, home aides, some of the folks that are frontline who are not, the uptake of vaccine is not good.
Yeah, you know, this is where it's always important to realize that healthcare professionals are human beings too. So they have all the same stuff that Dr. Bell and Muriel were talking about, right? It exists among healthcare professionals. Now, among the sort of, I guess, the licensed independent providers, it was a much higher uptake, but in nursing, it was pretty low. It was around 50%, and then some institutions a little bit lower than that. In the long-term care facilities, the residents were taking the vaccine upwards of 90% of the time, but it was well below 50% in the staff. So all the stuff that was said about the clients of behavioral health professionals is also true of in terms of these healthcare professionals and staff in these healthcare systems. We need to educate, but we also need to really acknowledge their anxiety, speak, validate it, all the things that have been said. I won't repeat them, but you know that needs to be done with these people as well. Don't just assume that because someone is working in a large medical center that they don't have those sentiments and those anxieties.
And I know at VDH there are a number of people who are working on two sorts of communities to improve uptake, faith-based communities, long-term care facility communities. We have our work cut out for us. We are out of time. I am extremely grateful to Dr. Oliver, to Dr. Behrman, Dr. Bell, to Dr. Ezria Evans, to Donald who has facilitated. I'm very, very grateful to all of you for taking the time to do this. And I thank everybody who took the time to participate. We are the messengers. So thank you. Oh, and Donald is reminding me that we appreciate your feedback on this session. Should we do more of them? If we really appreciate your feedback, here is a link. It will be in the chat also, a live link. So we love your feedback on that. And I thank you all for attending.
Thank you. It was a pleasure.
Thanks.
It was a pleasure. Thank you.
Good night, everyone.
Thank you, everyone.
Bye.
Good night. Thank you.